really every single patient deserves to be screened for this treatable illness that, unfortunately, when left untreated, leaves our patients at a greater risk for a poorer quality of life and outcomes after stroke.
Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 138 of the Strokecast. Today's episode is brought to you by the fine folks at Modus Nova. To find out if Modus Nova can help you recover the use of a limb after stroke, visit strokecast.com/Modus Nova. And by the team at Likeminded. To find out if the Likeminded program is right for you, visit strokecast.com/Likeminded. Depression after stroke it's not something that gets talked about very often. Granted, it's not as obvious as using a wheelchair or an arm sling or not being able to speak, but it can be a big deal. And it's a lot more than grief or feeling sad. Depression can interfere with rehab, with recovery, with adjusting to a new life in general, and more. Dr. Laura Stein from Mount Sinai Medical Center has been researching post-stroke depression to help more medical practitioners recognize it so they can better empower stroke survivors in their recoveries. So now, let's meet Dr. Laura Stein. So Laura, thank you so much for joining us on Strokecast this week.
Thanks for having me, Bill. It's really my pleasure.
So, let's start off with, just sort of setting some baseline information here for folks. What exactly is depression? Is it just feeling sad?
I think that's part of the challenge, is that not everybody knows what depression is, and especially post-stroke depression. There have been very specific criteria for diagnosing depression that are outlined by what's called the Diagnostic and Statistical Manual of Mental Disorders. And we're currently at the 5th edition of what's more informally called DSM. The DSM does not have a diagnosis for post-stroke depression, but they have very formal criteria for a diagnosis of a major depressive syndrome or episode, which has criteria that may help us think a little bit more about what this really means for patients with stroke. The first thing that is a requirement for a formal diagnosis of major depressive syndrome or episode is that the patient has to have 5 or more of a list of symptoms that are present most of the day and nearly every day for a minimum of 2 consecutive weeks. And at least one of those 5 symptoms must be a depressed mood or loss of interest or pleasure. And then the other symptoms that can be considered in meeting the criteria are insomnia or hypersomnia, so sleeping less than one would like or more than one would like, a change in appetite or weight. So the next symptom is psychomotor retardation or agitation. And I think the simplest way to think of this is either be a slowness of movement or perhaps a listlessness and more agitated state. The next would be low energy. The next is poor concentration. The next is thoughts of worthlessness or guilt. And then the last is recurrent thoughts about death or suicide. So, this is a laundry list of symptoms, but I think the key thing for people to take away from this formal diagnosis is that it's either a depressed mood or loss of interest that has to persist over a period of 2 weeks, and perhaps even more importantly, it needs to cause significant distress or impair one's functioning. Now, where this gets really challenging in making a formal diagnosis is that it's not supposed to be caused by a substance, a medical disorder, or a responsible loss. And I think almost anyone who knows someone with stroke could acknowledge that there's really a period of loss that a lot of stroke patients and their families go through. And so I go through all of this only to highlight it can be very challenging to formally diagnose depression, and it can look very different in each individual patient with stroke and also without stroke.
And what's really interesting, and I'm sure is compounding that challenge, is that a lot of those things that you listed, hypersomnia or insomnia, can be a direct result of stroke, regardless of depression. I mean, it is extraordinarily difficult to sleep in a hospital. It's a terrible place for trying to sleep. When we start talking about lack of or slow motor reaction, again, very common as just a natural result of stroke. I mean, a lot of these things are just things that can just be physical manifestations of the stroke, of hemiparesis, of the sleeping environment. And to put all of that together, especially in that inpatient time, it's got to be very hard to tease that apart.
I could not agree more. And there are a couple other challenges in the inpatient setting, which, first of all, many of our stroke patients don't spend a full 2 weeks in the inpatient setting, and many of them are still going through the response to loss. And some people would say, well, it's too soon to diagnose post-stroke depression. Others might say, I'm not really so concerned about meeting that 2-week criteria, and even if some of this is a response to loss, I can still pick up on really meaningful information about someone's mood and someone's loss of interest or pleasure that should lead to potentially considering a form of treatment for depression following stroke, and perhaps sooner rather than later.
How does that then all compare or relate to the other common stroke-related condition, which is emotional lability or pseudobulbar affect, where it can be just the slightest emotional thing somebody's involved in, or seeing a slightly touching commercial on TV, or even just doing some physical exertion can result in just weeping and crying, or heck, even laughing at completely inappropriate things. I mean, is that then an aspect of depression, or is that just a completely separate thing that just further complicates the diagnosis?
Well, you raise a really important topic that unfortunately is very common after stroke, and especially early on after stroke. I think as a non-psychiatrist and a non-behavioral neurologist, I tend to think of the emotional lability or pseudobulbar affect, as a form of emotional dysregulation. And I tend to think that it's completely separate from a reflection of underlying depression. And in fact, like you suggested, it just complicates trying to tease out what might be the underlying depression and mood disorder versus what might be emotional dysregulation that's completely separate from depression.
So we've already got a lot of challenges then in figuring this out. Obviously, in the inpatient scenario, it's going to be a lot tougher. If somebody is able to continue getting treatment and access to the medical system in the more chronic phase, once we start getting that 6 months, 12 months outside of the actual stroke incident, it probably becomes a little bit easier to tease those symptoms apart.
I would agree, and I would hope that our systems of care are set up in a way that patients have the appropriate follow-up to be screened for and treated for depression in that post-acute hospitalization as well as that post-acute or subacute rehab period. But I do have concerns that our systems of care are inadequate, and we are perhaps underdiagnosing and undertreating this really important complication following stroke.
Yeah, that I would certainly agree with that. I mean, I think even when we look at some of the specialties, I mean, we had Dr. Karen Sullivan on the show. I guess it was may have been up to 2 years ago now. And she is one of only 900 or so neuropsychologists in the United States. And there's definitely a gap in the care aspect from
from that perspective.
Absolutely. And I would argue that every member of the continuum of care for patients with stroke has an opportunity to at least screen for and potentially treat post-stroke depression. And that the more we can raise awareness of the condition and empower people to screen and treat in effective ways, hopefully the better our outcomes will be for our stroke patients.
Definitely. I think a lot of folks, when we start looking at sort of our pop culture understanding of psychology and things like that, I think we're getting a little bit more awareness socially of depression, which is good. But one of the other things a lot of folks don't really understand outside of internet memes is anxiety. And what is anxiety then from your perspective or from a DSM perspective?
DSM, of course, has a formal diagnosis for generalized anxiety disorder. It's not quite as complicated as major depression is, but it is characterized by excessive worry or anxiety that is difficult to control, causes significant distress and impairment, and occurs on more days than not for actually at least 6 months. And I guess I would emphasize with both of these diagnoses, there has to be some impact on one's ability to function in the world and live a meaningful life. And I think that would be a take home for anyone who's thinking about, am I or is my loved one being negatively impacted by symptoms of depression or symptoms of anxiety? Is quality of life being impacted in a meaningful way? Perhaps we should be looking for changes in one's trajectory following stroke to clue us in to when we may be potentially missing or failing to fully address post-stroke mood disorder.
Very much so. I mean, and that could manifest in ways like, suddenly, not participating in one's recovery due to worry about not recovering or further injury, or really any sort of different ways that it could impact what you want to get out of life and what your personal goals are.
Absolutely. And I think patients and their families know the absolute best and most about when they or a loved one are seeing a change from one's baseline.
Absolutely. And that's an important thing there too, is understanding the baseline, understanding where somebody is to understand how things are different. Understanding where we are today becomes very important for understanding whether or not somebody's impacted by these conditions. And, it's similar in what I tell folks all the time is that, especially early in the days of stroke, take lots of pictures and videos, because you may not see the change over time, but when you can go back and look at that baseline down the road, you can see tremendous recovery that you may not have otherwise noticed.
Absolutely. I think that's great advice. And I always am trying to help patients think about the long game, but in the process, appreciate incremental gains. And I think those incremental gains are the hardest to actually see and realize the significance of.
One of the things I've encountered in, conversations with other folks and in looking at reactions of therapists is that you can be working with a therapist and suddenly you get a little bit of movement in a limb, and a therapist, an OT or a PT will just be thrilled with that and super excited. And that's great, because we got to celebrate those victories. But that's because they're seeing you come from 0 to 1. Whereas you still see yourself as a week ago, you were at 100 and now you're at 1. So there's different perspectives when you have different baselines to look at. So what did your research actually show then about the relationship between post-stroke depression and anxiety?
We focused on the outcome of depression. However, anxiety was a really important part of what we learned. And we actually did two related studies of the same data set. We were using Medicare data, which includes patients with stroke 65 and above. And importantly, we only looked at patients who hadn't received a diagnosis of depression in the 6 months before. And in the first study, we were comparing the risk of new onset depression in patients with stroke to patients with myocardial infarction. And the reason why we chose this comparison group is that we thought, well, it's a population with similar demographics, comorbidities, in the sense that risk factors.
And just to be clear for a moment there, myocardial infarction is medical talk for a heart attack.
Yes, we were comparing the risk of new onset depression in patients who suffered a stroke to patients who suffered a heart attack. Then we wanted to look at, in this same first study, what were the strongest predictors of post-stroke depression, because if you identify predictors, maybe you can do a better job of screening for post-stroke depression in patients who you've identified as being high risk. What we found was that the risk of depression was approximately 50% greater among patients who had a stroke compared to patients who had a heart attack. And when we looked at that stroke population as a whole, we found that stroke patients with a history of anxiety were 1.7 times more likely to develop depression than patients without a history of anxiety. So, it's really something to take note of, that a history of anxiety was the strongest predictor of who was going to develop post-stroke depression. And perhaps we need to do a better job of using that information to try to screen the most high-risk patients who we know have this predisposing history.
And that's a really useful tool to understand that and to, again, then focus on things we want to pay attention to and to be aware of. I mean, so as I understand what you're saying here is that patients who have a history of anxiety are, much more likely to develop post-stroke depression than stroke survivors who do not have a history of anxiety. However, even among the stroke survivors who do not have a history of anxiety, they are much more likely to develop post-stroke depression than folks who had a heart attack.
So maybe we should think about these as two sort of separate questions.
Okay.
The first question being, among patients with stroke, when we compare them to patients with heart attack, who's more likely to develop depression following that event? And what we found was that the risk of depression was about 50% greater among the stroke patients and heart attack patients. That was sort of question one. And then question two was, what were the strongest predictors of developing depression in those patients with strokes? We separated the stroke patients from the heart attack patients, and we just looked at our patients with stroke. We found that those who had a history of anxiety were 1.7 times more likely to develop depression than those stroke patients who did not have a history of anxiety.
Got it. So we're not really, the research is not there yet to specifically then combine those two questions into one further result to come out of that.
That's right. Not from this kind of analysis. Maybe in the future we'll investigate this important topic.
And I think that's one of those things, too, that's important to consider when we're talking about the work of researchers and what researchers do versus what we see the general population or pop culture doing when we approach research studies, is that a lot of folks outside of the research community will start extrapolating results that may or may not be supported by the research. And that's one of those things that's so important about peer reviews and the process behind research and looking at things for publication is making sure that we are talking about very specific questions and getting the answers from those very specific questions and not sort of overreaching and overgeneralizing in ways that the research might not yet support.
Yeah, absolutely. I couldn't agree more. And unfortunately, it happens all the time.
So, I mean, this is probably not something that was sort of outside the scope of this particular research, but maybe this is something that just needs more research to understand. What do we know about the cause of post-stroke depression? I mean, is it a direct result of, the dead brain cells and the really messed up things stroke does to the neurotransmitter ecosystem in our heads? Or is it more about the social and societal environment people encounter after stroke, or their change in perception around their self-worth and their role in the family and business and in life? Do we know? Is it a physical thing that's triggering the depression, or is it all of this outside stuff?
Yeah, I mean, that is such a great question. It is one of those things that we don't truly know the answer to, in my opinion. And I suspect it's a complicated combination of many of the things that you have mentioned. And part of the reason why we wanted to compare stroke and heart attack patients was that we think that there is a stroke-specific process that's causing depression, and that there are some changes to the brain that are significant and, like you suggested, perhaps altering the neurotransmitter ecosystem. And so we need to do a lot more to understand this underlying reason for post-stroke depression. One thing that I'll just point out is that there has been some research that actually shows that patients who have TIA or minor stroke and, don't have the same long-lasting deficits actually show that depression exists in those populations. And that also supports the idea that, ischemia to the brain can be associated with depression, even when there's no significant disability. So we have a lot more work to do to understand what I think is a complicated and really multifactorial underlying reason for developing post-stroke depression. And probably it means that our treatment approaches need to be interdisciplinary, multifactorial, and, not just a one-size-fits-all approach to appropriately treating depression following stroke.
Well, that's interesting what you say about TIAs. I mean, I think one of the things that's going to be very interesting, especially over the next 5 years or so, is we typically think of a TIA as a stroke-like experience where the symptoms clear, a clot clears itself very quickly, and the difference between a stroke and TIA is that after TIA, you're left with no physical disabilities or no stroke-related disabilities beyond that first 24 hours. I think what we're starting to see with the tremendous strides in thrombolysis, the use of the TPA, clot-busting medications, or mechanical thrombectomy, where we run a catheter up through a blood vessel in the thigh, in the groin, and drag a clot out within a few hours of the onset of symptoms, is that a lot of people can leave the hospital with no actual stroke-related deficits, in some respects mirroring the experience of the TIA patient. So it'll be interesting to see how those things correlate in the future, as well as how they impact depression.
Yeah, we have just so much more work to do. You highlighted some of the great things about the field and the way that we've come so far, but yet we still have so far to go.
So one of the other things that we're starting to see more about, and featured a researcher, a gentleman by the name of Brent Strong, a couple of weeks ago, who was looking at some of the differences in the population of stroke studies based on sex. So does your research show any differences in post-stroke depression or its manifestations after stroke between men and women?
This is a very interesting topic, and the second study that we did in Medicare patients was to compare the risk and predictors of new onset depression after stroke in females compared to males. And as part of this, we wanted to see whether there were differences in sort of the trajectory of that development of post-stroke depression in females versus males. And what we found was that our female stroke patients had a 20% greater risk of developing depression than our male stroke patients. And importantly, this risk remained persistently elevated over the 1.5 years of follow-up that we had for these patients. Obviously, association doesn't mean causation, and there's a lot that needs to be fleshed out on this topic. But going back to your question about the underlying cause of post-stroke depression, are there unique biopsychosocial components to post-stroke depression that differ by sex? And we're even farther from answering that question than we are from answering the question about what's causing post-stroke depression, but it's just something to think about.
It's great that the question is at least being asked in a way that maybe it wouldn't have been asked in the past. So the other thing is, because we're working with Medicare data, which provides a tremendous amount of data and a great way of accessing this data, but that does also mean that it is limited to folks 65 and above, because folks who are typically under 65 are probably not going to be receiving Medicare. We have other ways of providing care or not providing care in the U.S. healthcare model, but Medicare pool itself is going to be limited to 65 and above. Of course, that only then captures about 2/3 of the stroke patients, with roughly 1/3 of stroke patients being under age 65. So what can we say about how well or how much of this data or this research can be applied to the younger stroke survivors in their 20s, 30s, 40s, 50s even?
Yeah, I'm really glad you asked this question, and it brings us back to the point you raised earlier that we have to be careful not to extrapolate the results from one study inappropriately and apply them to, say, the wrong population. I will acknowledge that this study only looked at patients 65 and above. And what I can tell you is we are actually working on an analysis of adult stroke patients 18 and older that's nearly complete and almost ready for submission for peer review. So I would love to come back in the future and talk to you more about that. But
absolutely,
I think stroke in the young is such an important topic. And, we need as much information about how stroke affects our young population as much as we do about our older population, and especially with things as important as mental health. So I hope I can give you more information and a more direct response to that really important question in the future.
That is a very responsible answer. I think one of the things that becomes really interesting about that is once we start looking at sort of that dichotomy between 65, above 65 and under 65, not only are there, the typical different comorbidities or other health conditions that accompany, being post 65, but also that whole role that work and providing financially does play in a person's definition of themselves and how they feel productive and how they feel they contribute to their household and society in general in a different way. So with this information that we now have about the role of anxiety in post-stroke depression and the greater incidence in post-stroke depression, what ought the clinicians that we encounter be doing with this, whether we're talking about physiatrists, rehab doctors, physical therapists, occupational therapists, speech language pathologists, all of the other folks in the clinical environment that we may be working with, the nurses, even the CNAs and the rest of the community. What ought they be doing with this information?
I think the biggest thing to emphasize is that every single member of the stroke community has an opportunity to screen for post-stroke depression, and perhaps we should have a slightly different index of suspicion in those who have a history of psychiatric comorbidity like anxiety or women, but really every single patient deserves to be screened for this treatable illness that, unfortunately, when left untreated, leaves our patients at a greater risk for a poorer quality of life and outcomes after stroke. And I would also say patients should be screened at all time points following stroke. And we talked about the early acute hospital period, but let's not forget, a year and a half, 2 years after stroke, we need to be thinking about these patients just as much as we think about them in the early acute period, because, our data suggests that this elevated risk for depression following stroke persists long after one's actual stroke, and we don't want to discount the implications that it has on one's quality of life and one's outcomes at any point after the stroke.
And that's really important, is when we start looking at that long-term perspective. When we start talking about what depression impacts somebody's life and their life goals, that can, of course, then also manifest, as we touched on earlier, a patient then not pursuing their outpatient rehab or their home exercise program or whatever else they ought to be doing to recover from stroke and to continue to progress because of the impacts of post-stroke depression.
By all means, and I would think that one's goals following stroke are so different in the short term and from the long term, and you have to just think about how we are helping our patients and their caregivers best meet their goals and what barriers they may be facing at various time points in their post-stroke journey.
So we want clinicians to be sort of regularly screening for it as they screen for other things. What about survivors and caregivers? What can they do with this information?
Boy, I think they are best equipped to watch for and identify signs and symptoms of depression in themselves and their loved ones, and they should not be afraid to have a conversation with their team members who are supporting them in the post-stroke period. As we've spoken about, any concern for a change in one's post-stroke trajectory should be taken seriously, and all of the possible contributing causes should be thoroughly investigated, including possibility of post-stroke depression. So,
this is such important stuff, and this whole field is just fascinating with how quickly we're learning things and how much we have learned in just the past 20 years. What was it that drove you to pursue this particular course of research in depression and anxiety?
Well, I think it stems from just an interest in trying to better understand and improve upon the outcomes for all patients with stroke. And, it's disheartening to think that post-stroke depression can affect a third of our stroke patients, and that these patients who are experiencing post-stroke depression have poorer functional status, are more likely to require healthcare utilization, poor quality of life, higher risk of mortality, higher risk of recurrence. I can go on and on with all of these unfortunate outcomes that are associated with post-stroke depression. And so, anything that I and others can do to better understand how to identify and treat post-stroke depression has the potential just to improve quality of life and outcomes for our stroke patients. And as I have said, we have just so far to go, and I think I have a lot of hope, because I think of post-stroke depression as a very treatable illness, and we just have to work together to think about how we best identify and meet the individualized needs of our stroke patients who are experiencing post-stroke depression.
Well, I think the other phrase you use there that I really like is, folks who are encountering post-stroke depression do have higher healthcare utilization. When we're talking about folks with higher healthcare utilization, that means more doctor visits, more hospitalizations. That means a ton of more money spent. So post-stroke depression is expensive, not just in the life of the patient, but it's expensive for hospitals, it's expensive for government-provided funding, and it's expensive for health insurance companies. So regardless of what we think about the structure of the healthcare finance model in the United States, it's in the interest of all parties to screen for and treat post-stroke depression as early as possible, to give patients better outcomes, to give relief some of the challenges families face, and to ultimately lower costs and free up beds in hospitals in a more expeditious fashion.
Yes, that's an excellent point. And if these patients are having frequent encounters with the healthcare system, then we should see each encounter that our stroke patient has as an opportunity to identify and treat this condition.
Let's then step back a little bit. I mean, absolutely, it's definitely a fascinating space, but you chose to pursue this career in neurology and stroke research, and this is not an easy path because there's a lot of stuff there, and I'm sure there's a lot of math involved too. So what was it that drove you personally to pursue a career in neurology and in stroke research? And we're all very grateful that you did.
Well, I think I've always been drawn to things in life that facilitate a meaningful connection with people, and that connection has looked different depending on what phase of life I've been in, but there's something so unique about the nature of neurologic illness, as well as the neurologic history and examination, which leads to, in my opinion, one of the most meaningful doctor-patient relationships that one can have. And unfortunately for our patients, at a truly life-altering moment. And so, there really is no greater privilege than being able to learn a patient's story and hopefully have a positive and meaningful role in the future course of that patient's story by helping be a member of their care team and helping to learn a little bit more about the things that we just don't know enough about when it comes to patients with stroke.
And that brings us to our hack of the week. But first, I want to talk about sponsor Modus Nova. Modus Nova makes devices to help with hand and foot rehab. These are robotic, air, and AI-powered exoskeletons that you wear while playing games on the Modus Nova touchscreen display. They help you move your hand or foot to control on-screen actions. If the action is too difficult for you, they provide more assistance. If it's too easy, they provide resistance, all while creating reports to show you just how well you did. Modus Nova helps you get in the repetitions that you need to drive neuroplastic change in the brain and help you get back an affected limb after a stroke. Visit strokecast.com/Modus Nova to learn if Modus Nova is right for you. Use promo code STROKECAST to save 10% off your first month. And now back to our hack of the week.
The only wonder drug that I know of is, actually there are two, exercise and pet therapy. And my favorite prescription to write for a patient is actually for a dog.
So, I mean, Laura, if folks want to know more about you and what you're up to, where should they go?
Boy, that's a good question. What I can tell you is I will be pretty busy over the next few months learning how to become a new mom.
Oh, congratulations.
Thank you. But, after that, I will look forward to continuing to treat stroke patients and train the next generation of neurology residents and stroke fellows here at Mount Sinai, and at the same time, continuing to pursue my research looking at disparities in access and outcomes for stroke patients with a really great team of research mentors and collaborators that I have here at Mount Sinai.
Well, fantastic. And we'll have links to the study. We'll have links to the Mount Sinai program. It's a fantastic program. And all of that over at strokecast.com/depression. And Laura, this has been great. I really look forward to hearing about some of these other studies you're working on, especially if that other one gets did pass peer review, to hear those outcomes and to be able to share that again. And thank you so much for sharing everything today. This has been fantastic.
Thank you, Bill. It's really my pleasure to have the opportunity to speak with you today.
The nonprofit Likeminded is our other sponsor this week. Likeminded is a membership group for folks living with brain injury and created by Jane Connolly, also known as Heal the Brain with Jane. When you join Likeminded, you get access to live online classes hosted by other stroke survivors and medical professionals. You can learn more about the therapies you can engage in, the mindset around effective recovery, and how to deal with life after stroke. You also get a private text messaging group to get answers to even more of your questions. It's a great way to support your recovery in what's really a wonderful community. Get the support, accountability, and direction you crave and deserve for just $45 a month. Use promo code STROKECAST for 20% off your first month. I'm wrapping up this episode as mental illness is currently enjoying a moment in the spotlight thanks to the events happening in Tokyo. Gymnast Simone Biles withdrew from a number of Olympic events due to mental health concerns and how that can impact her physical capabilities. She talked about losing her place in the air while vaulting, getting the twisties as gymnasts call it. And when that happens, she's at much greater risk of injury and earning a low score and hurting her team. She made the brave choice to withdraw. A couple of things jump out at me about this story. And just to be clear, I am in no way, shape, or form criticizing Simone for putting her team and her mental health ahead of her medal ambitions. First, this discussion around the twisties is something many stroke survivors are actually familiar with. As I understand it, basically her proprioception went wonky. Hers was thrown off while intentionally doing leaps and twists and twirls 10 to 15 feet off the ground. Mine would go wonky when I walked forward while turning my head to the side. Proprioception is how we orient ourselves in space. It's how we know where our hands and feet are relative to our body, and it's essential for moving and balancing safely. In the case of stroke, the brain damage can mean that our brains have difficulty making sense of the physical signals that our bodies are sending us. In the case of a gymnast, they have to be highly attuned to that stuff, or they can get seriously injured. In addition to having that focus, I imagine in many of those stunts, the fluid in the ear that helps us know up from down is sloshing around like a soda can in a paint shaker. What we also know is that the line between physical illness and mental illness is a lot fuzzier than many people realize. And Simone's decision has got a lot of people talking about this stuff because this stuff matters. Which is why I'm also glad that Dr. Stein and her colleagues are doing this research. Major depression ruins people's lives, even when they don't have a brain injury. It literally kills people. And what we know now is that stroke survivors are at high risk of depression after stroke. Survivors with a history of anxiety are at even higher risk, and it's not just a grief response to the newfound disabilities or a change in lifestyle and life plan. It's deeper. And folks with depression may experience less motivation to do the work of recovery, to do the work of adapting to the new lifestyle, or even, to do the work of living. Bringing attention to the issue, especially in chronic stroke, is important. Major depression is treatable. It may not be easy, depending on the person involved, the details of the stroke, and the availability of resources, but it is possible. And treating it begins with recognizing it when it's present as surely as we recognize hemiparesis or aphasia. I was lucky in that this was not one of the consequences of my stroke. A couple of years ago, I interviewed Dr. Nirav Shah about a research project called the FLAME study. You can hear that conversation over at strokecast.com/Nirav. The study appeared to show that the use of Prozac, or in its generic name, fluoxetine, after stroke could drive additional neuroplasticity. Unfortunately, later studies, namely one called the FOCUS study that actually came out a month after my interview with Nirav, could not duplicate the results. My stroke actually happened in between the FLAME and FOCUS studies. Because medications like Prozac were generally cheap with minimal side effects, the hospital protocol was to recommend starting patients on an SSRI like Prozac or Lexapro. And that's how Lexapro, also known as escitalopram, ended up in my daily pill case. In addition to the potential of enhanced motor recovery, there was also the side effect of reducing the chances of depression. So it made a lot of sense to make that part of the treatment protocol. And, that could be why I escaped the trap of depression, and could be the reason why my emotional lability mostly cleared up in a few weeks after stroke. Continuing a medication like this, though, is an important conversation to have with your doctor. Last year, I talked with my doctor about if it made sense for me to, stop taking it, especially in light of the FOCUS study. And my doctor basically said, yeah, we can do that, but dude, it's 2020. Okay, maybe those weren't her exact words, but she had a point, and the current solution is working for me. The point is that depression is a big deal. Recognizing it is important. Preventing it is great, and treating it is crucial. So tell others about the risks of depression after stroke. You can give them the link strokecast.com/depression, where at that link, not only can they listen to this episode, but you'll also actually see the official definitions of major depression and generalized anxiety disorder, as well as resources that you can follow to learn more. You can also visit that link for the links to Dr. Stein's research and other episodes that we referenced in this conversation. So just go to strokecast.com/depression for all that and more. Be sure to subscribe to the free monthly Strokecast email newsletter for more updates from the community at strokecast.com/news. And of course, as always, don't get best. Get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you soon.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.